Good day, everyone. Welcome to part 1 of the lecture series on olfactory groove meningiomas, diagnosis, surgery, and outcomes. In this first session, we'll build the foundational understanding necessary to approach these tumors with confidence. Olfactory groove meningiomas, though relatively uncommon, pose unique challenges due to their location at the anterior cranial base. Their proximity to critical structures like the olfactory tract, frontal lobes, and optic apparatus means that even benign tumors can produce significant neurological and neurobehavioral symptoms. Today, our focus will be on identifying and diagnosing these tumors. We'll begin with their anatomical and epidemiological background, then discuss how patients typically present, ranging from subtle personality changes to complete anosmia or visual deficits. We also dive into radiological evaluation, especially the hallmark findings on CT and MRI, and briefly cover key differentials to keep in mind. By the end of this session, you should have a solid grasp of how to recognize olfactory groove meningioma clinically and radiologically, setting the stage for our next discussion on their surgical management. Olfactory groove meningiomas, a subset of meningiomas that, while benign and slow-growing, pose significant clinical and surgical challenges. These extra-axial tumors arise from the arachnoid cap cells along the dura overlying the cribriform plates of the ethmoid bone and the frontosphenoid suture. Their deep midline location near vital neurovascular structures, including the optic nerves, anterior cerebral arteries, and frontal lobes, makes early detection and careful surgical planning critical. Let's explore what makes this tumor unique in both presentation and management. Olfactory groove meningiomas typically demonstrate a symmetrical growth pattern centered around the crystal galley, giving them a midline dominance on imaging. However, in some cases, the tumor may extend unilaterally or involve adjacent structures such as the planum sphenoidale and tuberculum cellae, which can lead to compression of the frontal lobes or optic apparatus. Understanding this pattern is crucial for both radiological assessment and surgical planning, as even subtle deviations can influence the choice of approach and extent of resection. Olfactory groove meningiomas account for approximately 4.5 to 80% of all intracranial meningiomas, and among anterior skull-based tumors, about 22% are pure olfactory groove in origin. Interestingly, 7% of patients may harbor multiple meningiomas, suggesting the need for thorough imaging. These tumors show a female predominance and are rare before age 30, with peak incidence in the 5th and 6th decades of life. Due to their growing nature, symptoms often develop insidiously over months or even years, with up to 25% of patients symptomatic for more than 3 years before diagnosis. This chronic course can delay presentation and treatment. When approaching olfactory groove meningiomas surgically, a deep understanding of the anatomical relationships is critical. Superiorly, these tumors abut the frontal lobes and anterior cerebral arteries when large. Posteriorly, they encroach on the olfactory nerves and chiasm, while inferiorly, they rest above the olfactory nerves, ethmoid sinuses, or even the nasal cavity in invasive cases. Small tumors often represent anatomical planes. A2 segments of the anterior cerebral arteries are typically spared, separated by arachnoid and cerebral tissue. However, in larger lesions, anterior cerebral arteries branches like the frontopolar arteries may be stretched or adjacent to the tumor capsule, requiring delicate coagulation and dissection to avoid vascular injury. Olfactory nerves are also at risk. In smaller tumors, they are usually displaced laterally and may be preserved, but as the tumors enlarge, the nerves can become compressed or unrecognized, especially with broad dural attachment or bone involvement, limiting the chance of preservation. The optic apparatus, nerves, the optic nerve and the optic chiasm may be pushed downward and posteriorly, often correlating with visual deficits. Arterial supply primarily comes from the ethmoidal, meningeal, and ophthalmic arteries, entry through the midline skull base, emphasizing the need for meticulous control during skull base drilling and tumor devascularization. Olfactory groove meningiomas cause symptoms primarily through gradual compression of adjacent neural structures rather than infiltration. Early in the disease, compression of the olfactory bulb and tracts leads to progressive anosmia, often unilateral. Because this sensory loss develops slowly, patients may not notice it or clinicians may overlook it during initial evaluation. As the tumor extends posteriorly, optic chiasm compression may occur, leading to reduced visual acuity or bitemporal hemianopia, particularly in larger tumors. Additionally, increased intracranial pressure from mass effects can result in headache, nausea, and papilledema. Superior tumor expansion affects the frontal lobes, especially the orbitofrontal cortex and medial frontal gyri, producing the classic signs of frontal lobe syndromes. Patients may exhibit apathy, personality change, disinhibition, and executive dysfunction, often subtle and delayed due to the frontal lobe compensatory capacity. Seizures can also occur due to cortical irritation, particularly in larger or more invasive tumors. Rarely, patients may experience acute neurological decline if the tumor undergoes rapid growth or due to perilesional edema. When evaluating patients with olfactory groove meningioma, it is important to recognize that symptoms are often subtle, progressive, and easily overlooked. The most common presenting complaints include visual disturbances, typically due to compression of the optic apparatus, frontal lobe dysfunction, presenting as apathy, disinhibition, or memory issues, headache from raised intracranial pressure, anosmia, which patients often do not notice or report, and seizures, especially in larger or more invasive tumors. Now, regarding anosmia, although almost universally present on examination, is rarely reported by the patient, highlighting the need for routine olfactory testing during assessment. If unilateral olfactory function is preserved, it should be carefully documented, as this may influence surgical planning with the goal of preserving at least one olfactory nerve during resection when feasible. In the diagnostic and preoperative workup of olfactory groove meningiomas, radiological evaluation is indispensable. The goals with imaging are threefold: to accurately define tumor extent, understand its relationship with surrounding neurovascular structures, and differentiate it from other anterior skull-based pathologies. MRI with contrast is the gold standard. It typically reveals a well-circumscribed extraaxial mass with homogeneous enhancement and characteristic dural sign. MRI also provides crucial insights into peritumoral edema, tumor consistency, paranasal sinus evasion, and potential brain evasion, all of which inform surgical planning. CT scan complements MRI by better delineating bony changes, hyperostosis of the cribriform plate or planum sphenoidale, and detecting extension into the paranasal sinuses, which is vital for cranial-based reconstruction. For larger tumors or those aborting critical vasculature, magnetic resonance angiography or digital subtraction angiography may be used. This helps evaluate vascular encasement, especially at the anterior cerebral arteries, and in some cases, guide perioperative embolization if the tumor is highly vascular. Finally, it is important to differentiate olfactory groove meningiomas from similar appearing entities. For example, tuberculum cellae meningioma, which tend to sit more posteriorly, esthesioneuroblastoma, which have a nasal origin and tendency for bony destruction, while gliomas are intra-axial tumor without a dural tail. Such differentiation is key to accurate diagnosis and choosing the optimal surgical approach. Let's briefly recap what we have covered in this first part of this series. We have explored the anatomical origin and clinical behavior of olfactory groove meningiomas, reviewed our key presenting features, including anosmia and personality changes, and examined the characteristic finding on imaging, particularly MRI. We also highlighted the important differential diagnoses that should be considered during evaluation. Understanding this fundamental aspect is critical because timely recognition impacts both surgical planning and outcomes. In the next part of this series, we'll transition from diagnosis to management, focusing on the various surgical approaches used to assess and safely remove these tumors. I look forward to walking you through these operative strategies in part 2. These are the selected references. Thank you for listening.